Welcome, everyone. My name is Prashant Yadav. I'm a senior fellow here at the Center for Global Development. Welcome to today's seminar. Hopefully, all of you who are joining need no reminder how crucial it is to have access to essential medicines to meet priority healthcare needs of populations around the world, but particularly in low and middle income countries. And this is an issue that has been recognized widely. It's by no means new. CGD has worked on this, many bodies and work streams at CGD on demand forecasting, on antimicrobial resistance, on value for money, on a more recent body work on procurement, some new work that we're doing on forecasting the shortages of essential medicines due to COVID-19 or other supply disruptions, are all focusing on one component or another of the broader theme around access to medicines. Debates about access to medicines have often focused on how do the roles between what companies or pharmaceutical manufacturers ought to do, what should governments be doing, what is the role of international agencies and global donors. But much of these debates have been lacking evidence, partly because data about access to medicines in a rigorous, systematic manner is often very weak. There is little longitudinal data to compare how things are progressing. At the same time, we do see a number of initiatives that have been started, some by global agencies, but many new ones that have been started by global pharmaceutical companies, and there have been attempts at measuring, ranking, or understanding their impact in some forms or the other. The Access to Medicines Index, for instance, ranks the top companies on their access strategies and its impact. But what we've not seen is a rigorous evaluation of a particular access program. So I'm excited that today we are going to see results from some recent work that has been done around it. We have 4 speakers, and the plan for our session today is Peter Rockers, who's an assistant professor in the Department of Global Health at Boston University, and Veronika, who's an associate professor in the Department of Global Health at BU, are going to first present the results of a cluster randomized trial they did in Kenya to evaluate the impact of Novartis's Access program. They'll introduce us what the Access program was. After hearing the research findings from Peter and Veronika, we'll go to Michael Fierce. Michael is the head of social innovation and strategy at Novartis, and he will share his viewpoints on what did Novartis learn from this rigorous evaluation, what are things that Novartis is taking away from this. And then we'll go to Irene Veru. Irene is the Deputy Chief Pharmacist at the Kenyatta National Hospital in Nairobi, Kenya, and is in many ways at the front lines of this, is a clinical pharmacist who is treating patients, is also the lead of the Therapeutic and Formulary Committee at Kenyatta. So she will share views on what does this truly mean from the standpoint of improving access for a practicing pharmacist. So that's our plan for the day. We'll have ample time for questions and discussion. I hope those of you who are joining are staying with us to share questions, comments, debate, critique. All of that is welcome. With that, I want to pass it over to Peter and Veronika for their presentation, which will be about 25 minutes. After which we'll go to Michael. If you have questions, please keep putting them in the chat or other channels that you're using. So with that, over to you, Peter and Veronika.
Thank you very much, Prashant. This is a great honor and pleasure being here. And I will start by sharing our slides that we have prepared for the next 25-30 minutes presentation. As Prashant said, my colleague Peter and I will first present on the results of the randomized controlled trial of Novartis Access, and then we have Michael and Irene commenting on that. So it's really a great honor and pleasure to talk at the Center for Global Development on this topic. And I would like to thank the audience for taking the time to be with us today for this important discussion. So first of all, a quick declaration or a quick clarification of our goals with this presentation. So our main goal is twofold. First, to provide really an example of an evaluation of a pharmaceutical industry-led access program. Today we are talking about Novartis Access for that matter, but really to situate that evaluation also in the broader context of evaluating access programs and contributing, as Prashant just highlighted in his introduction, in the broader context of creating knowledge and evidence on these programs. What does our presentation not do? It doesn't go into depth into the evaluation design, the data analysis, the study limitations, although we will mention them, but the purpose of this presentation is making available important results of this evaluation for a much broader audience than just experts or methods freaks in evaluation. So really to make to take away broader lessons learned and share them with the audience and discuss them. So the role of the industry in achieving sustainable development goals is quite clear and has been, I'd say, the point of the role of the industry in general, not only for pharmaceutical industry, but private sector and even for-profit private sector has been made very clear in the Millennium Development Goals, and then from the Millennium Development Goals also in the Sustainable Development Goals, and explicitly here manifest itself in goal number 17, to encourage and to promote effective public and public-private and civil society partnerships. So very clear, manifest and explicitly said that these partnerships are important to achieve the Sustainable Development Goals, and within the Sustainable Development Goals, obviously also universal health coverage and essential to universal health coverage access to medicines. Let's take a look more specifically as one sector of the industry, the pharmaceutical industry, and its roles and its activities. And over the past decade, industry, obviously including the pharmaceutical industry, has made important contributions to social goals. Important to note is obviously that the pharmaceutical industry has different types of activities. And here I'm just kind of schematically laying them out. We have industry activities that are really their core business, which are mostly financial, and about which we know a great deal from many companies who are publicly listed companies that share information about their business activities with shareholders. Then we have two other parts of activity, and depending on the company, obviously, we have activities that are here to the right, which are philanthropic activities. Several large pharmaceutical companies have a foundation that is largely philanthropic and focuses exclusively on achieving social goals. And then we have this other light blue box here, which stands for or signifies hybrid programs, which are a mix of social and business goals. And the program which we focus today in our presentation is this type of mixed or hybrid, we call it hybrid program. But important to mention is that obviously overarching to both of the light blue and dark blue box, we can call them access programs, or the activities that these kind of two activity arms are pursuing are access programs, many access programs, and access programs have common features. For the purpose of this presentation, we will define them as those that are led by pharmaceutical companies. They are financed largely by pharmaceutical companies, and they either pursue these kind of like hybrid goals, or they pursue purely philanthropic goals. So when I use today the term of pharmaceutical-led access programs, I'm referring to either the light blue or the dark dark blue box, and particularly for our main focus on the Novartis Access, I'm focusing on this kind of hybrid type of programs that combine social and business goals. So what do we know about not the core part of the pharmaceutical business activities, but what do we know about the access programs, the ones that are either hybrid or philanthropic? Our team at Boston University did literature review looking specifically at these access programs of the pharmaceutical industry. We did a systematic review of these, and what we found in this systematic review, we found 120 pharmaceutical access programs focused on medicine, so 120 access to medicine initiatives led by the pharmaceutical industry. And we found that 7 of these have been evaluated plus published. So obviously there might have been evaluations which we didn't know about because they weren't published. We found 7 out of 120. And 3 of them had been rigorously evaluated. What do we mean by rigorously evaluated? We use the GRADE instrument, which is an accepted instrument that assesses the tools and the methodology used to evaluate these programs. And by this GRADE definition, by this assessment tools definition, 3 of them met the criteria of having been rigorously evaluated. So takeaway message from this is that by and large, many of these access programs have not been rigorously evaluated. So you might say, why do we care about measuring or evaluating these access programs? There's good intent, that's sufficient. We would argue that this is there is a good reason for caring about measuring these access programs for a variety of reasons. One is for sure to facilitate shared learning. So if one access program, let's say Novartis Access, would be a fantastic access program, and we would like every pharmaceutical company to do that, then obviously it's really worthwhile disseminating this knowledge gained from this program and identifying exactly what are the success factors of this program. Why can it be successful, and why should it be adopted in which context? We also obviously would like to promote accountability in particularly towards the communities in which the programs are implemented, but also in the wider community and the global community of letting know which are the access initiatives that take place and for which we also want to give credit for those access initiatives. And then to inform an efficient resource allocation, which goes to avoiding, for instance, duplication of programs, for instance, do not work or even cause harm. So leading up to giving this background, now let's go and look further into the example that we will give today with the evaluation of Novartis Access. We were approached by a team of the Novartis company of talking about their intent to evaluate a new access program that had been designed, the Novartis Access program. And we were very excited to discuss the possibilities of evaluating this program. And this was discussed even before the implementation of the program. And before engaging into a more serious discussion about this program evaluation, we decided mutually to agree on common principles for this evaluation. What should be the guiding principles for this evaluation? And we laid them out and made them available in what we call a master service agreement between Boston University and Novartis Access. The master service agreement is available for the public on our product website. One guiding principle, which is applicable to many academic efforts, is the agreement to have the freedom to develop, analyze, and evaluate the program as from the academic perspective with the academic independence. Then we agreed upon that this evaluation should be methodological, with a certain methodological rigor, accepting best practice standards for doing a program evaluation. We also agreed mutually on a transparency, making, for instance, the study protocol public, making the instruments public, making the data set at the end public for verification, for learning, for shared learning, even in the approach that we had taken. And you can see these instruments, the data set, everything uploaded on our publication site. And then also in terms of obviously the focus, what were we setting out to evaluate? We decided on using a public, prioritizing public health. We were doing an evaluation of the social and public health goals. Obviously, we were not focusing on the business goals in our evaluation. So what is Novartis Access, and what is the goal of Novartis Access? What is the intervention we are setting out to evaluate? The program provides a basket of reduced price NCD medicines to public and non-profit sector program in program countries. In other words, this is not a private sector focused initiative. It's an initiative and a program that is focused on the public sector and the non-profit sector to begin with. In the basket, in the portfolio of medicines, as you can see, the majority of the medicines are generic medicines that are targeting NCD non-communicable disease medicines. So we have already two characteristics and features of the program that just makes it very distinct from many other programs that are happening. It's not an infectious disease focused program, communicable disease program, and it's also not focused on the private sector. Thirdly, it takes this kind of portfolio approach, which means there's cross-subsidy between the products. And also another feature is it uses a wholesaler through which this program is disseminated in Kenya, which is specific now to the Kenyan setting. It uses the wholesaler METS, the Mission for Essential Drugs and Supply, the METS wholesaler, as its wholesaler through which the program is implemented in Kenya, which might be different from other settings. But for the settings that setting that we are focusing on in our presentation, it is one wholesaler in Kenya that distributes to public and non-profit sector facilities for this program, for the Novartis Access program. What is the study aim of our evaluation? If this is the intervention, the price reduced NCD medicines in this basket approach, what is the study focus of our evaluation? It is to evaluate the impact in terms of availability and price on non-communicable disease medicines. So we registered this randomized control trial in clinicaltrial.gov, and the protocol is also published. So then in terms of study methods, we chose a randomized control, we chose the cluster randomized control trial. The clusters were the counties in that case. We chose 8 counties. We used a sample of all public and non-profit health facilities within the 8 counties that were served by METS. And we did a random sample of 639 households throughout these 8 study counties. And we had eligible individuals who were diagnosed and treated for NCDs that were part of this program basket of this program, which is hypertension, asthma, and respiratory diseases, which is asthma in this case. We had an intervention period of 15 months, and we used the facility data and the household survey as our data source. As you can see here, these were the 8 counties. What is important to mention that really these counties were spread. We avoided through that kind of spreading on the study counties a kind of spillover effect. We didn't have common borders of these study counties. In terms of data analysis, what is important to mention how we define these outcomes. The primary outcome were the availability and the price, as I said. We had secondary outcomes which are not focused in this presentation today. The primary outcomes were availability at facility level and at household level. And it was defined, the availability was defined as the percentage of the health facilities that have the medicine on stock on the day of the assessment, irrespective whether the medicines was Novartis brand or was the and how many units were available. And then in terms of price, we calculated the price in form of the median price ratio. Median price ratio is defined as the median price per month and then divided by the international supplier price. This helps and allows you to aggregate prices. And this is a very, let's say, commonly used method to measure prices. So let's switch now to the results of this impact evaluation that we did. And what you can see here in the slide is a focus on some of the medicines Novartis that were part of the Novartis program, amlodipine and metformin, which are highlighted here in red, for which we found evidence of a positive impact on availability. As you can see here on the unadjusted and adjusted odd ratios, we controlled for the adjusted odd ratios for the value of the outcome baseline. We adjusted for the facility levels, which means were there primary care facilities, were there hospital facilities. We adjusted for the ownership of these facilities. What you can see here also from the table is that for other medicines, here as example, hydrochloroside, salbutamol, which were also part of the Novartis program basket of medicines, we did not see a difference. Overall, and this is here my second table that I will show, second result table that I will show. Overall, you can see here in the first row of the table, overall for the availability for other medicines, we did not find a difference in the availability or a mean probability of the availability for other medicines in the Novartis Access portfolio. And when you then look at the price, we also, and this is here in the red box in the table, we did not find an effect on the median price ratio of the medicine. So combining the price analysis for all medicines, but also for individual medicines, we did not find at facility level an effect on the median price ratio. Let's move now onto the households and the effect of Novartis Access on the households. So when you look here at my table, you will see that controlling for baseline, that is the value of the outcomes at baseline, the age of the household members, sex, material status, education, household size, and household wealth, all these covariates, we did not find an effect of Novartis Access on availability at household level. So these were like high-level results on the primary outcomes of Novartis Access at facility level in terms of availability and price of the medicines, and in terms of the availability at household level. Let's now examine a little bit more in my remaining part on what might be the reasons for why we did not find an effect apart from the availability on amlodipine and metformin, which were two medicines at facility level in which we found an effect. So overall, what you see here in the slide is the regulatory approval time for the medicines that were included in the Novartis basket. And I think this is an important indication here on this slide in terms of the approval time, in terms of the importation time, for what we can kind of deduce when the medicine would be available at facility level. And what you see here very clearly in the slide is that approved were amlodipine, metformin very early on, together with some other medicines, but very early on. And then some other medicines in the basket approved much later on. And then also with the imported metformin, salbutamol, and amlodipine were some of the medicines first imported. So from this already, you can deduce that the chances for having the program permeate and reach the health facility is much lower for many of the other medicines in the basket. And then let's look at what we call the surveillance information that we measured in between our measurement of baseline and end line of the evaluation. As I told you, that was 15 months between. What we did in between was we called facilities and we called households on a regular basis. We wanted to get a better understanding what happens in between the baseline and the end line about the primary outcome variables. And here on this slide, you see an overview of some of the medicines, of the important medicines in the Novartis Access basket. And what you see here is that the availability of amlodipine and the availability of metformin significantly increase, whereas for the other medicines, it keeps relatively low, which is in line with information I showed you before on the registration part. So actually the permeation of the program in that case was most successful for amlodipine and for metformin. Another factor that is also important to take into consideration when we look at the interaction between the program and the context in which the program was implemented is the essential medicine list in Kenya, which dictates which medicines are available at public sector facilities. The essential medicine list in Kenya has an indication at which level of care certain medicines should be available. And as you can see here in the red box or in the column that says level, that many of the medicines in which we were interested were only available at hospital level, at level 4 or above. And this means that, again, with the program penetration, thinking about will the program reach primary care facilities, which were part of the program, this is much to a lesser extent, because from its, let's say, intent, which medicine should be available, there's a much lesser chance for these medicines to be available at that level. And then in terms of other considerations that are important to think about why we found the results we showed you. One is obviously we did an evaluation at kind of end line after already 15 months, which is a very short time considering global health programs and how long it usually takes for a program to permeate and to reach the points at which it's meant to act. So relatively short period of time. Then what we also did, and which I did not go into that detail in my presentation, we also did interviews. We did interviews at health facility level. We did interviews at household level to ask a lot about access to non-communicable disease medicines in Kenya, about the awareness of Novartis Access at these two levels. And what we found was a relatively low awareness. 5% had heard at facility level about Novartis Access, which was very low, at particularly considering after 15 months, knowing the program, obviously less we can deduce from that, probably less demand because it's less well known. And then $1 per month for these medicines, we would need to consider the context of what are the other offers, what is the price of competitors and competitor products. And what we found is that there are some other products, for instance, amlodipine products on the market that are offered for less than $1, or metformin offered for less than $1, which is obviously important from the perspective of the demand. And then also we chose METs. Obviously, we measured the program only with facilities that were served by METs, but in general, important to think about Kenya in its context, where many public health facilities are served by KEMSA. And the facilities that we studied might also have chosen a KEMSA as their provider, were more used particularly to using KEMSA. So what are the study limitations? All evaluations have limitations, and it's important to take them into consideration. One of them is that obviously the percentages that we showed in terms of availability of medicines need to be considered in context of what we did. We asked patients, or we included only patients who were diagnosed plus prescribed non-communicable disease medicines. So when we found a high percentage of patients having medicines we need to consider that not being indicative in general for the accessibility of non-communicable disease medicines in Kenya, because we had this eligibility criteria, diagnosed plus having a prior prescription for an NCD medicine. And then in terms of counties, obviously we excluded counties with a lower procurement volume for meds, because we wanted to capture those counties for which we had a chance to measure the program permeation, obviously. But therefore, this study is not indicative for and representative of all counties in Kenya. And then we had a substantial number of respondents for whom we could not measure the price at household level, and therefore we couldn't measure the price, our primary outcome, at household level. So in summary, it is important Novartis Access had little effect after the 15 months after our evaluation. What is important to acknowledge is it is a non-communicable disease medicine focused program. It is operating in the public sector, which very few programs in general take as a focus of their program. The Access program operates in a complex health system environment, and reducing the wholesaler price might not always and immediately translate into improved patient access. And the program developments need to conduct a thorough needs assessment to understand the complexity of the context, which I just alluded to with my prior slides, in terms of essential medicines, in terms of registration times, in terms of many other contextual factors, which, as we have seen, turned out to be very critical in the interaction of the program with its context. And the evidence generated of this study will obviously improve and inform Novartis efforts going forward, and we will hear more from Michael first in this presentation about it. So I hand it over now to Peter.
Great, thank you, Veronika. I'm just going to spend maybe 5 minutes talking a little bit about some broader efforts that we have underway to develop measurement and reporting standards for pharmaceutical industry-led access programs. So I think Veronika at the start of the presentation provided some of that context of really, we think a key part of the value of this Novartis Access evaluation is sort of starting to develop some standards around how the industry measures and reports on their programs. Sorry, next slide. So published along with the evaluation itself was a nice comment that made a very similar point, which is to say that that the rigor and actually evaluating this type of program in this manner hopefully sets a standard that companies can follow in the future to start to rigorously evaluate their programs. So I should say, so we operate a reporting platform called the Access Observatory. You can visit it, accessobservatory.org. And really, the goal of the Access Observatory is to facilitate better, more standard reporting on industry-led access programs. So Veronika mentioned two of the key reasons why we want to develop stronger standards around measuring and reporting on industry-led programs. The key one is this accountability function. So really, developing standards supports a common understanding between industry and stakeholders about really what these programs are aiming to achieve. And then, really it's the start, or it's a necessary first step in the industry articulating the goals of their programs using that kind of standard language, and then holding themselves or being held accountable towards documenting progress towards achieving their goals. So having these kinds of measurement standards is sort of a first step in developing some of those accountability mechanisms. And then the learning function. I mean, really, standards are necessary to start to build up a coherent body of evidence on what works. So if you really want the science of access as a public good to start to really develop, you need some of these standards. So the Access Observatory is a reporting platform. We have, at this point, 94 different industry-led programs have been reported into the Access Observatory. the structure of the information and data that companies report into the observatory follows a framework that we've developed. So this slide shows the sort of three-part framework. So we have a taxonomy of strategies which helps to provide some structure around what companies are actually doing from a strategy perspective. Each strategy has a logic model, a theory of change that really lays out inputs, outputs, outcomes, impacts of how these various strategies are meant to achieve public health goals. And then finally, building on the logic models and theory of change is a standard data dictionary. And so when companies are reporting into the Access Observatory, they have to complete a set of standard forms. They have to adhere to this framework so that everything that they're reporting is really standardized in this manner. And through standardization, again, we build up more of a broad understanding of what the industry is doing in this space. So at this point, we've published 3 annual reports in the observatory. We have 94 programs that are currently registered, 75 of which are still currently active. This slide just gives you a sense of really what kind of new understandings we can derive from this kind of standard approach. So the figure on the left tells you, what are the strategies that companies are actually using in their access programs. And one thing that becomes clear when you look at this figure is that actually the vast majority of programs are using the same 3 strategies. They're doing health system strengthening, which by and large is actually training healthcare providers. They're doing a lot of healthcare provider training. They're doing these community awareness campaigns where they might be holding a community event or just disseminating information packets into communities to try to, essentially increase awareness around disease and treatment options. And then they're doing some direct service delivery, sometimes mobile clinics, sometimes public health days. So these 3 strategies are by and large what vast majority of the industry is, at least the snapshot that we get from what they report into the observatory, which is not everything they're doing, but from our perspective seems to be documenting a vast majority of what they're doing. It gives us a sense of what countries they're working in. So we can see the map figure on the right. There's actually a high density of programs in a few select countries, Kenya being the most, having the largest number of programs, 28 this past year. I think one of the things that, that this kind of standardized approach illuminates is first of all, where there are gaps in what companies are doing, but also where there are potential synergies or collaborations. So in the last year or so, there's been a recognition that there's so much going on in Kenya that a more coordinated approach by the industry might make sense. So there's some efforts in that space. I think the last thing I'll just say on the observatory, really the ultimate goal, of course, is to build up evidence on really what strategies are going to be most effective. In order to do that, there needs to be a greater investment, in the types of evaluations that generate that type of evidence. So far, there's been improvements in companies starting to collect and report indicator data on their programs, but the vast majority of what's being reported at this point is outputs. I would say that, in order to get greater investment in actual impact evaluation, there probably need to be some structural catalysts put in place. And we could talk a little bit more about what those might look like in the discussion. But as of right now, I think there is an effort and some progress in collecting and reporting data. But really, we're not yet at a point where we're developing that body of evidence that could really help us identify those next generation of programs that are really going to have high impact. I think I will stop there. Say thank you very much.
Thanks, Peter. Thanks, Veronika. This is great work, of course, and raises questions about a lot of things embedded in what your findings are, other similar efforts which have tried to reduce wholesale price and have seen slightly different effects, what could have led to that. Thanks also for highlighting the timelines on importation, product registration, other limitations such as the types of wholesalers that were used or the counties that were getting meds product versus KEMSA or other wholesalers. So I think it's quite comprehensive in terms of describing the context and the cluster randomized trials immediate findings. With that, we want to go to Michael first. Michael, first of all, thank you to you and colleagues at Novartis for signing up for a rigorous evaluation of Novartis Access and hopefully not only helping internal discussions, but putting this out in the public domain will help other companies in designing their programs. So thank you for that effort. With that, comments, insights you want to share about how Novartis Access views this, also the motivations and how you built an internal convincing case to do a rigorous evaluation, and where are you headed with this now?
Hello to everyone on the line, and thanks, Prashant, for the invitation to speak and to all in front of their computers to listen in. You know, Prashant, you asked me to speak about 3 to 4 things, one of which is, why did we do this? What was the motivation, the primary motivation? How did we react to certain findings that we saw specifically in the midline? And then we spoke, or I mentioned a number of times, what does this mean going forward for the company? And lastly, what is the value of a collaboration of that kind between academia and the private sector, which I believe is a very worthwhile topic to discuss in a little bit more detail. Now, let me start with talking a little bit about the motivation. I think, like in most other companies, Novartis wants, of course, that the corporate responsibility programs or the access to medicines programs do work. These programs are typically well intended, but I have to say that if intentions were enough, the world would be a much better place. And I would say that in CR circles, in the pharmaceutical sector, but also beyond, there is a kind of a persuasive belief in the good deed, which means people believe that well-meaning investments will automatically create positive results. Now, that's obviously not true. It's assumptive, it's not based on scientific insights, and it's a barrier to learning, because we actually don't know what is going on the ground. Now, Novartis has a strong legacy in the access to medicine space. Some people might know our efforts in the malaria space. We have launched a social business program already in 2007 in India, the Rogia Paribas program. And these were all successful in a certain sense. But the truth is also that we could not show really more in terms of success than patients or people reached, which is a relatively simple output indicator, but doesn't tell us much about the specific elements that do work, and I would say the success of the program at the end of the day. Now, I have been invited by Richard Lang to go to the WHO some years ago and present the Rogia Paribas program. And the room was pretty packed with people, and there was a lot of interest in the room, but also a lot of critical questions. And the main question, I would say, was at the end, how do you know? Is this just what you believe that it works, or do you actually know? Now, the problem with that program was it was already in place for a number of years. So we missed to put in place a baseline, which made it very difficult for us then to put a proper measurement and evaluation program around this Rogia Paribas program. So when we created Novartis Access that Veronika and Peter have introduced, we said, let's do this differently now. Let's be smarter than last time, and let's actually create evidence on whether the program works or not, because it would be beneficial for not just the private sector, but also for the wider global health community, we thought so. So the specific goals was, of course, that we want to create evidence, whether it works. We wanted to create some kind of a managerial dashboard, which is not just carrying, let's say, the classical financial metrics, but also social impact metrics, because when we call something a social business, we can't just measure the business impact, but we also need to measure the social impact. We also recognized after a certain period of time that we would do good if we would create a common good in order to lower transaction costs for other companies to join that cause, and also to do measurement and evaluation. And at the end of the day, what we realized is that measurement is not an afterthought, or it should not be an afterthought, but the design principle of creating access programs. Now, what did we do when we learned about the midline results and the results in more general terms when that Veronika has presented? You know, we sat together with the Boston University colleagues for hours and hours, and we actually changed the program design because we realized that certain elements didn't work as well as we have hoped. So as an example, you know, the program, as Veronika has presented it, was originally planned to serve public procurement agencies and NGOs. And since the result in terms of increased availability was not where we wanted to have it, we said, okay, if this is not the channel that creates the impact that we want, let's also go into the private channels and let's try to increase availability via using this channel as well. This was not an easy decision to take because, again, the program was designed for something different. And of course, going into, let's say, private distribution mechanisms with such a program can also create some conflicts within an organization such as Novartis. So this is just an example where we really use the results for changing certain elements of the program and try to do better afterwards. I think what we also learned is very clearly that we should do much better in terms of having a thorough initial assessment before we start and plan the program. It became very clear to us in the whole, I think, journey we went through with Boston University. We looked very carefully into more than 60 indicators when we designed the program. But having said this, maybe those indicators were not well enough chosen, and maybe we should have looked into other things. And I would do it completely differently today, also in conjunction with an academic partner that can give us guidance how to do this better. Now, how do we take this forward? This was the third thing. I think we have raised the interest in Novartis from some colleagues to do similar things. And we are having discussions with some people how to apply similar rigor and similar methods for their, let's say, global health programs. This is not an easy conversation because it's not an easy thing to do. And it takes time, it takes dedication, and it takes resources to get something like this off the ground. But we are having the conversation with some colleagues, as said. And since we have created this global health unit recently, there is also an increasing interest in the metrics and the work that we have done with Boston University, specifically in regards to the review of Novartis Access and other social business program. At least this is what I hope for. Now, the value of collaboration between private sector and academia, I have to say the value is immense. I have not had many other projects during my career that I enjoyed so much like this one. We had very intense hours with Peter and Richard Lang and Veronika and Monica, and really try to understand what is going on the ground and try to digest the findings and then take the right conclusions. This was not just an intellectual, I would say, endeavor, but also a very pleasurable thing to do. But at the end of the day, what we can learn from that, I believe, is that we can learn a lot from academia, how to run rigorous measurement and evaluation activities in the private sector. The knowledge is typically not there in the private sector. What I believe academia can learn about is the challenges a private sector company is encountering when it is committed and ambitious to do something big like Novartis Access. This is not an easy thing to do. That's a rocky ride. And sometimes I believe there is not enough knowledge about the roadblocks and the barriers you encounter when you do something ambitious like Novartis Access or other access programs. So at the end of the day, what this can help us is to create a completely different level of dialogue, which is evidence-based and not driven primarily by ideology or opinions from both sides of the party. And I think this collaboration can help us to achieve a more transparent understanding and a better understanding of how we increase access to medicines at a much wider level than in the past.
So I hope I was able to answer some of the questions or comment some of the things that have been said by Veronika and Peter. And of course, I'm happy to answer questions that will follow later in the webinar.
Thank you, Michael, and thank you once again. I think not only for a private company, oftentimes we find that even for public agencies and including global agencies, it's hard to commit to a rigorous evaluation of a program. I mean, it does bring out many things that you are still trying to build, change, tinker. But so we commend the fact that you've committed to an evaluation of this sort and also put it out in the public domain so that others can learn. I want to go to Irene Veru in Nairobi. Much of this discussion, Irene, is being focused on evaluating at the facility level, but I mean, managing the largest hospital pharmacy and seeing a number of the products which were a part of Novartis Access being prescribed to your patients. What do you take out of this? Do you think the findings tell you something that is new, aha, or did you expect this all along? And what is your take on reducing wholesale price and expecting availability and patient price to go down versus potentially other ways of addressing access to medicines? So over to you, Irene, and thank you for joining us. Irene, you're muted. We don't hear you yet. We're still not hearing you, Irene.
Is that better? Hello. Okay, thank you. So the findings do not surprise me because one of the things that happened when the Novartis Access program came to Kenya was that the Access program came in through MEDS, the Mission for Essential Drug Supply, and many of the public health facilities would usually procure from KEMSA, like Veronika rightly put it. And like for the largest referral hospital where I work, which is the Kenyatta National Hospital, we usually will procure products through a tender system. And it's usually a 2-year cycle where we invite bidders. And so MEDS usually does not participate in the Kenyatta National Hospital tenders. And that obviously meant that in the initial years, we were not able to access the product. Later on, the products were available through KEMSA when they became available through the private distributors that were able to bid through KEMSA. So the products were available through KEMSA. So that meant that then the government facilities or the public facilities could then access the products through KEMSA. So the findings that in the initial years there was sort of a drag are in tandem with the fact that the products were not available through KEMSA. But also just to note that, like Veronika put it, that many of these products are not available, were not available or were not listed on the Kenya Essential Medicine list in the 2016 list, and they're still not available or listed in the 2019 Kenya Essential Medicine list. So obviously that means that even though the products are available through an access program, then we are not able to procure them and have them available for our patients because these products are not listed on the essential medicine list. The country is in transition to the universal health coverage, and the medicines for the different diseases, including non-communicable diseases that are listed on the Kenya Essential Medicine list are what are going into the Universal Health Coverage list, meaning therefore that the Novartis Access program medicines are not what are available to our patients, whether it's through a procurement system and a KEMSA or through the Universal Health Coverage system. So I think for the policymakers, that means obviously that the essential medicine list system is working, and that an access program does not necessarily mean that prescribers will move from what's listed to what's available through an access program. So I think on one end, that's a good thing for the policymakers, for our colleagues at the national government who are working tirelessly to come up with this essential medicine list. I think that's a good thing. It's a good thing that our list is solid in the sense that it is not influenced by what's available through an access program. I think Prashant had also asked me to speak about challenges. In addition to the availability through KEMSA, which is our Kenya Essential Medicine, Kenya Medical Supplies Authority. So in addition to the challenges that the products were not available through KEMSA, I think the other issue was that the strengths of medicines that were available on the Novartis Access basket were not necessarily those that were listed. So there are some products that had different strengths listed on the Access program, but were not available or listed on the Kenya Essential Medicine list. So obviously for those products, then they will not be available in the health facilities and they will not get to the households. The molecule may be available, but then the strength that is in the Access basket is not what is available. We also had some products available at relatively low costs and already in the market, and Veronika spoke about that earlier. So for some of these products, we have our patients really wanting to stay with the brand that they already were used to before. And so even with the product being available at $1 on the Novartis Access basket, they were not, many of our patients did not switch from the brands that they were already used to the brands that were now available through the Access program. So I think the opportunities to improve access, one of the things that can happen, not just for Novartis, but for the other companies, is to look at what medicines are listed. So, and what are the medicines listed on the Kenya Essential Medicine list? What are the medicines listed on the referral hospital formularies? Because the referral hospitals have slightly broader formularies than the Kenya Essential Medicine list has. And also looking at our treatment guidelines and working on the medicines that are listed to give access products. So the good thing with the Novartis program that I see is that the list was quite broad. Many other companies will actually just work with one product and usually will work with a high-end, high-cost product. So that means that not very many patients can have access to those. But when we work with a broader list of products, then the overall cost of treatment can actually come down. The last issue that Prashant had asked me to speak about were the issues about what other countries might take from the Kenyan experience. I think that's a difficult question to address. And I think as we spoke through the different aspects and challenges, maybe there are issues that other countries have picked or participants on the call have picked from our experiences. But finally, I'll speak to our regulatory challenges. I think that came out in the presentation that our listing or registration process for our products takes really long sometimes. So you can start your registration process and it will take about a year or 2 years to have your process completed to the Pharmacy and Poison Board. And I think that delay in registration can also mean a delay in the program, and it would mean that the program does not have an impact, but there were challenges and bureaucratic processes behind that probably delayed the process of having these products registered and therefore accessible to the people. Thank you so much.
Thank you, Irene. This was very insightful and helpful to put this in the context of how you view this from the vantage point of a large referral hospital's pharmacy. If you have questions, so those of you in the audience who have questions or comments, please submit them. If you are joining via YouTube, there will be a section on YouTube. If you're joining through Twitter, it's a hashtag CGD Talks, or you can email them to events@cgdev.org. We'll get to your comments in a few minutes. But let me start by first thanking all four of our speakers. I want to start by mentioning something which is once again not new and has been a part of the debate about access to medicines, which is what are the parts that a company controls and contributes, and what are the parts that the government and public stakeholders carry out. And I think the comments from Irene highlighted some of that, which is, it's important to recognize what's on the essential medicines list. It's good that in Kenya there is higher adherence to standard treatment guidelines and the essential medicines list, but at the same time, challenges such as the long lead times for product registration, approval, importation, etc., are other things that need to be overcome. But I want to start by posing a question to Veronika, Peter, and perhaps Michael and Irene as well. So I think we've seen other programs, many of which have been much larger in scale, which have based on the logic model of reducing wholesale price or reducing ex-factory price, and then hoping that it'll reduce the price to the patient or the price to the payer and will increase availability. The most prominent one that was evaluated large scale was the Affordable Medicines Facility for malaria. The product subset was much smaller, but the reduction in wholesale price in the 6-country evaluation does show significant decrease in retail price and higher availability. So I think when we look at what are the key takeaways from this program, I worry if someone starts drawing the conclusion that the logic model of reducing ex-factory price or reducing wholesale price doesn't lead to impact on price and availability. Many of the caveats that you described aptly, Veronika, are probably the reason why this is different than a globally run program. But any comments, thoughts you have on this, would love to hear your viewpoints. So let me start with Veronika, and then we'll ask others if they have comments on this. So Veronika.
Thank you, Prashant. Yeah, I love your question, because that when we hope to change the price at one point of the distribution chain, would that really translate into reducing prices at facility level or then even at patient level, which is the end user, which we care most about, what happens to the end user, up to the extent that some program evaluations even have not bothered to mention the end price of the users and have just maybe measured the price somehow in the somewhere in the supply chain, but did not take into consideration what happens at the end user point and the importance of looking at the end point, which we have done in this evaluation, really measured at household level, prices at household level. For sure, it's absolutely critical to do so throughout the supply chain and think very carefully about which mechanisms are at stake and how could the provider, in this case the manufacturer, how could the manufacturer influence, which is price setting, the subsequent prices that are charged along the supply chain. What was, I think, interesting about Novartis Access was we had not many points between the manufacturer and, so to speak, the end user, because it was or is a program that partly is channeled through the public sector, in which we only had one wholesaler, so one step, then it was in the facility, and then it was the end user. So this is actually a very simplified supply chain. We know about supply chains that are much more complex, where you have many more steps in between, where the likelihood of charging markups and therefore having a higher end consumer price is much larger. So with the Novartis Access, to begin with already, you have a much simpler supply chain that you're looking at, and much more likely to influence each of the price points. And I think for me, one takeaway lesson is, when you start designing your program, you need to have the prices of the competitors in the market. So what are other competitors charging? Would the price that this access program puts forward actually be competitive within the prices? Do you want to have a supply? Do you want to have a program that actually offers a product that is even lower priced, so that it would kind of create demand for the product in comparison to others? In this case, the Novartis Access, it was priced similar to others in the market. It was definitely not the highest or not the lowest, and for some of the products even it is still the lowest. I know from 2 cancer medicines that are within the Novartis Access basket, for which it's now attractive to the public sector to procure some of the cancer medicines within that basket. So right from the get-go, from the design of the program, it's really important to take into consideration the market factors and the supply chain to think. But definitely take on board your point of saying that definitely companies have the chance to create pricing programs that actually influences end user prices.
Veronika, follow-on question before we go to others on this specific part. I know that you said that there were facilities which were not routinely receiving supplies from meds, and therefore across the board we don't see a decrease in price. But is there any subgroup analysis? So if I was running a facility that was almost exclusively buying my NCD medicines from meds, and the price from Novartis to meds was reduced, and meds is a non-profit distributor, so most likely it's not that they are coughing up a big margin in between. So does a subgroup analysis show a price impact that is significant?
Let me hand it to Peter for this kind of analysis on looking specifically at Novartis and comparator products.
Yeah, I think coming back to Veronika's point about, really the way the portfolio is structured, you have these cross subsidies, and the greatest subsidies are on a few of cancer medicines that we really never even saw. And so I think it's just the nature of how the program was rolled out. The molecules that had the greatest subsidies really weren't made all that available, or we're still awaiting regulatory approval, or so we actually don't see many of them enough to document, whether those particular drugs had an effect on. But to answer your question directly, salbutamol is the one drug that actually there is some evidence. We weren't really powered, I would say, or the Novartis Access salbutamol doesn't show up enough to really say anything with any real certainty. But there's some evidence that I think that the Novartis Access salbutamol showed up at facilities, at a reduced price. So I think if you were to see a broader distribution, or some of those heavily subsidized drugs within the Novartis Access portfolio make their way into being more available at the facilities, you might see some of those price effects.
Okay, thanks Peter, Veronika. Michael, with one additional question, which has come out of what Peter just mentioned. So, the simplicity of pricing a basket at $1 a month is very appealing, and I think I can see the value and the pragmatism attached to saying let's just do $1 per month. But at the same time, the cross subsidy effect does lead to some challenges. So what is your take on a pricing scheme which is reduce each product individually by a certain percentage, versus or look at its comparator price or a benchmark price and say we'll offer it at a certain percentage less than the competitor price, versus choosing a $1 for the basket. Are there discussions around this that you are having?
Sure. And I think we already had the discussion months ago about a more targeted pricing approach on individual molecules that have been part of the portfolio for a number of reasons. And one is, of course, that some governments just can't buy portfolios. They do itemized tendering. And therefore, you have a, let's say, regulatory bottleneck in the model that you can only clear if you start to discuss individual prices of individual treatments or products that are part of that original portfolio or even go beyond. I just want to say one thing. I think price and affordability is for sure an important discussion, and I would fully agree we should not feel, let's say, should feel a tendency to now completely ignore that field and just do other stuff. Price and affordability is an important consideration that we need to think very seriously and carefully as a pharmaceutical industry about. There was, of course, a certain reason why we have chosen certain products into that portfolio. Of course, we looked into the essential medicines list, WHO one, and also the National Essential Medicines list of Kenya. But in the team, we discussed the following. How does the competitive landscape look like? What are the volumes of, let's say, the treatments that are available in Kenya based on the National Essential Medicines list? And would it make sense just to ship more volume of the same treatments to this country? Does this make sense? I'm not sure. Or would it be wiser to choose, let's say, molecules from the same treatment classes, but that are more innovative, and try to make an attempt to make those treatments available to the patients as well, with all the barriers that have been discussed and shown in the previous conversation. Another conversation is, yes, you can look into the essential medicine list and then find some molecules, but the truth of the matter is also that you might not be competitive from a pure cost side. So it doesn't make sense to include it, because it would not allow the company, in this case Novartis, to run a sustainable program. And again, this was thought and is thought to be a social business model, which of course also then considers sustainability as a main element of the program. So this is what I meant at the beginning. This is not easy thing to do. This is complicated stuff. The good thing now is we have strong insights, better insights, more information, and more precise learnings that we can work with than we had before.
Thanks, Michael. A question we are getting from Rachel Nugent, a colleague and strong collaborator in the NCD's work, is: have other pharma companies who are designing their access programs, have they sought input from either Novartis or from Peter, Veronika, Richard, others involved in this, as to how to improve the design of their access programs? Or in essence, the starting point of some of this was, will not only will it help Novartis, but will also create some kind of a global public good collective that can help other companies design their programs better, even global agencies. So is that happening? Are people reaching out and saying, are you willing to give your inputs?
It's a great question, and I would like to thank Rachel for raising that question. And this was exactly one of the goals of the seminar, to stimulate more interest, and not only from pharmaceutical companies, but from collaborators such as Rachel and many, many more who are interested in this field, to create a learning platform. And I think Peter started to lay out what we believe could be a very nice input into that discussion. The Access Observatory is now collecting information about many, many of these access programs, which then gives us, as Boston University or many, many other people, a much more solid platform for which we can have the discussion about what can we learn. So it's not only that I hope that people come to Boston University and talk with our team and get advice, but also that this is a learning opportunity for many, many more collaborators, Rachel and other many groups around the globe saying we use the Access Observatory, we look in what Access program exists, where they exist, what their goals are, what do they have achieved in order to design. But specifically to your question, Rachel, yes, we have had discussions, many discussions with many different groups and also companies, how access programs can be designed based on the evidence that we have collected, based on the information that we have available, and also larger literature and how they can be designed. And Peter and I have also written several proposals and making that a larger discussion, not only one-to-one. So we love to have the one-to-one discussions. We love to have the broader discussions with global health, let's say, about how we can institutionalize a learning platform. And also mentioned is funding and interest and a platform, a convener such as the Center for Global Development, a convener bringing together like-minded people and having this discussion. I don't know, Peter, if you want to add something to that nice question.
Yeah, I mean, I think, you know, the last 3 or 4 years to the observatory, we've worked with several companies, again, trying to get them a little bit more comfortable with, you know, pretty, I would say, standard approaches to monitoring and evaluation. And I think that it's a learning process, and I think there, you know, some of these ideas are starting to take hold, but it is a big undertaking to invest in, you know, and similar to what, you know, not every impact evaluation obviously has to be a randomized control trial. So there are multiple different ways to try to think about, you know, evaluating programs. And I think there's a handful of companies that are really trying to be forward thinking and forward looking in this. And I would expect more of this type of work to manifest in the future. As I mentioned when I do think that there are, you know, some structural catalysts that could be that this community should focus on in order, you know, to be a little bit more proactive in creating an environment where this is more normal. So I don't think we should just be waiting for companies to sort of reach out. And I think that there's a lot of work that stakeholders, that the global health community can do to create an environment where this is done more. So we're trying to do some of that work. But yeah, I think there's interest, and I think that there are efforts underway, and, you know, hopefully there'll be more of this. Michael can maybe speak to whether, you know, other companies have reached out to him directly to talk about his experience.
Yeah, definitely. I think a number of companies have shown great interest, not just in the program itself in Novartis Access, but also in the measurement and evaluation activity that we are doing together with Boston University. There is definitely a huge level of interest in this. And I guess that much of the interest was spurred or is spurred by the fact that this was developed as a business model and not as a charitable or another philanthropic activity by a big pharmaceutical company, which is a great thing, but also complicates things to a certain extent, because you need to work with different knowledge and expertise in order to make a business model work than working with an implementation partner based on a philanthropic intervention. Don't get me wrong, I don't want to downplay philanthropic interventions, but running a business in those kind of settings is a completely different thing, and it requires a different level of knowledge in terms of the patient journeys, pricing that we discussed, etc., etc. So there is huge interest, but I think we need to find better ways to really make the knowledge available that we have gathered through the activity with Boston University, but also through our own learnings in Novartis. I think we need to find a platform to have more discourse and conversation on that, because I believe it would help more companies to join and do similar things.
Thanks, Michael. If there are other questions, please keep sending them our way through the different channels, YouTube, Twitter, email. I wanted to ask Veronika and Peter about a related body of work. So I think we've seen from some recent CGD work as a part of the procurement report, some other earlier studies that, and Irene, mentioned that as well. Switching brands and the willingness to pay for one brand versus the other. I mean, there could be significant differences in that depending upon the type of brand, how long it has been used. So again, people may not be as willing to switch to Sandoz if they were getting something else, which they had some kind of association with in the past, or vice versa. And I know that you are either studying this or have studied this as well. So any insights you want to share about this phenomenon of willingness to pay for a brand and associated things?
Sure. Yeah. So we didn't know if we'd have time to talk about it, but as part of a recent survey we conducted, a follow-up with these households in Kenya, we conducted a small experiment, a bidding game experiment, basically to elicit willingness to pay, where we randomized households into two prompts. Basically, in one of the prompts, they were presented with a hypothetical scenario. Here's a month's supply of your medicine in the Novartis Access brand, and we showed them a picture of Novartis Access medicine. In the second prompt, it was a generic, unbranded form of the exact same molecule. And so then we elicited willingness to pay, and then so we have a slide with the results. I don't know how easy it would be to bring up, but I can just describe very quickly. I mean, really our goal with this was to try to understand, it's an important question of what kind of brand premium are patients willing to pay for generic medicines. And a lot of the literature suggests that they are willing to pay a brand premium, and most of it seems to be driven by concerns over quality. So that essentially, in a market where you might have high rates of, substandard medicines with respect to quality or fake medicines, how much is that brand worth to consumers? And so we looked at that. So the slide that's up right now shows, I mean, basically what we found was patients were willing to pay a 23% premium for the Novartis Access medicine on average. But really the willingness to pay that premium is concentrated entirely amongst sort of the upper half of the wealth distribution. So basically the wealthier households are willing to pay a 40% premium for Novartis Access versions of the same molecule. And the lower half of the wealth distribution is basically not willing to pay any premium. And so, I mean, this is consistent with, with qualitative, a lot of survey data suggesting people really are, that brand is meaningful and people are willing to pay more. I think it raises a policy question, around whether those premiums, what role does maybe the government have in regulating, whether those premiums are sort of a reasonable response to poor quality medicines, or whether they're sort of more related to some kind of, whether it's advertising. I mean, obviously with Novartis Access, there's very little advertising around Novartis Access, but I think the Novartis brand is probably what produces this willingness to pay premium. So I think that we're still in the process of writing this up, but I think interesting results.
Yeah, thanks, Peter. So I think lots of things are embedded within that, and some of it, at least previous studies have shown, some of it is also country of origin premium. So it's not to the brand and the company in particular, it's also where the product was manufactured, oftentimes gets a premium and so on. So I think just as you disentangle what all contributes to it, I think we would all love to learn and read about that So do keep us all posted. Daniel Crapper from PSI has a series of questions, and I think one you've attempted to answer before, Peter, but I think one of the things he's asking is that could the purchasers pick and choose which products they wanted, or were they mandated to buy the whole basket?
In terms of, sorry, go ahead, Veronika.
No, sorry, you go first.
So if I'm understanding the question correctly, this is more in relation to how Novartis Access works. What is the way in which, and Michael could probably respond to this as well. I mean, I think that the ways in which the portfolio was implemented in Kenya, Michael's probably best suited to answer.
Yeah, I guess so. If I'm a pharmacist at a facility, can I just selectively buy the metformin from Sandoz and nothing else, or do I have to commit to buying the portfolio? That's the question that Daniel is asking.
So you can't force people to buy everything, right? You need to allow to buy what is needed on the ground. I think that's a given, and you also can't force government to buy the full portfolio. Now you make an offer, and the offer was as it was, and that's then of course something the governments have to think about and decide what they want to choose from the portfolio, but you can't force.
Okay. Well, I think we are getting close to our time, and I know it's late for at least for Michael and Irene. So once again, I will thank all of you. This remains an important area of discussion, debate, research. I want to thank very much our panelists, our speakers today. And stay tuned, there is more to come, both on this topic that we discussed today, but other related areas at CGD and with our extended network of research collaborators. Thank you again for your time.
Thank you very much.
Thanks a lot. Bye-bye.
Thank you, everyone.
Thanks.